So hello, my name's Dr. Jonathan Mathers. I'm one of the anaesthetic consultants at the Lister Hospital, and I've sort of been drafted into intensive care now because of the COVID pandemic, and asked to give you a little bit of an overview of where we function in critical care with a view to you guys coming into critical care. And I think the first thing is, like, I appreciate that critical care is not your normal working environment. And I share that same issue with you because critical care isn't my normal work environment either. And what I wanted to do is just give a little brief presentation, a little bit of a video, a bit of just base info on how we function in critical care, so that when you do come to deploy to us from medicine or surgery or wherever you do work, you're a little bit more grounded so that you can get moving quicker, and hopefully learn lots and experience lots and participate and really help to make a difference. So the first thing to say to all of you is thank you so much for doing this. We do appreciate in critical care, it is sometimes a bit of a scary environment for any of us, and particularly with the risk of infection with these patients. And I think the first thing we wanted to mention to you is that really you mustn't worry. I think probably on balance, it's probably safer to be in critical care than on the wards because we know where the infection is. We cohort our patients appropriately, and therefore all the protective equipment's in place. There's no kind of sort of diagnostic query, and also you'll always have full support of the entire team at all times when you're there. And the large volume of the work that we'll be getting you guys involved in is going to mostly be routine, at least to begin with. But as your skills and your proficiency improve, then we will hopefully see you flourish in the ICU. And I'd like to also think that this is possibly a learning opportunity like no other. I've never worked in a pandemic. I've certainly not one of this magnitude, and it is a privilege and an honour to be part of the team that can help. And even in a general scenario, we know that bright and engaged trainees flourish in ICU from all the disciplines whenever they come to us. There's so much to learn, there's so much to develop. And although it may not be part of your normal day-to-day working, I think it will complement your knowledge and your capabilities long-term going through. So the things that I want to cover today are sort of the key things I think that will help in your day-to-day when you come into the ICU. So we're going to talk a little about sedation and weaning, why we do it and how we do it, a little bit about cardiovascular support, again, what's the thought processes going through our minds on the intensive care. A brief look, and it's going to be a very, very shallow look through ARDS, or acute respiratory distress syndrome, which is essentially what all of our COVID-19 patients are getting. A little bit about the principles of ventilation, and just a sort of rough understanding of how the ventilators work. Brief talk about renal support, or what we call renal replacement therapy, RRT. A little bit of chat about feeding, how we do it and what to expect. And a little bit about the general structure and routine of the ICU, and then also where we think you will fit in. I should caveat that the structure and the routine are obviously in a state of flux depending on how the unit is going to be dealing with the pandemic. So sedation. So why do we sedate our patients, and how do we sedate them, and how do we sort of gauge where we are? So the first reason is that being in an ICU is a very painful environment. If you want to give an idea of how uncomfortable it can be, just now pause this video, and what I'd like you to do is just sit wherever you're sitting. Don't uncross your legs, don't change your position, don't wiggle your fingers, don't move your head, don't move your neck, don't move your bottom, don't move anything. You can't swallow, so you're going to have the secretions pool in your mouth. You can blink and you can breathe, and just see how long you can hold that before it becomes unbearable. You'll probably last about 3 or 4 minutes, and then it'll just become too uncomfortable and you'll just want to move. And now try doing that and holding that position for 6 hours at a time, and that's what our patients go through. So there's a phenomenal amount of pain involved just from the fact that they can't move, so they get aching in their joints and in their muscles, as is to be expected. And also the actual presence of an endotracheal tube, which is a hard plastic tube. Your throat is phenomenally sensitive, and this hard plastic tube is put in there, so they're always having a sensation of gagging, and we then inflate a cuff at the base of the tube to seal the airway so that we have complete airway control. And that's literally squeezing against a very, very sensitive tissue base. So it's a phenomenally painful experience. And also, even if we could completely ablate the pain, it's a very frightening experience with people in all, it's a very foreign environment. No patients have ever been into ICU normally before or experienced it consciously. And you've got monitors beeping, you have a disordered rhythm, you have people coming in and out. You've got people like doctors like ourselves sticking needles into them. They've got tubes in area orifice. So it's a horrible situation to be in. So we usually give a balanced sedation that combines pain relief or analgesia with hypnosis, which is inducing a loss of consciousness or a loss of conscious awareness. In terms of how we gauge it, in our ICU, we use the Richmond Agitation Sedation Scale, or RASS score, as just a way of communicating, much like a GCS, where 0 is alert and calm, going positively when patients are becoming more agitated, so starting restless, agitated, and then combative. And then on the downward side, from just slightly drowsy, light sedation, moderate sedation, deep to fully unrousable, essentially 100% unconscious. And we will move up and down this sedation scale as is required for what the patient needs. You should be aware that prolonged over deep sedation has associated with a negative outcome in critical care, both in terms of how long patients have to spend on a ventilator. So if they're over sedated, they spend longer on there, and the longer you spend on a ventilator, the longer you are at risk of getting a ventilator acquired pneumonia or VAP. So generally speaking, in ICU, we titrate the sedation to a specified level that's ideal for the patient at that period of time. And the other thing to mention is this isn't sleep. This is a chemical coma. This is a coma where, much like as if you drank loads of alcohol and drunk yourself into a comatose state, that's exactly what we do. We sometimes engage in paralysis as well, particularly when patients are very, very difficult to ventilate, and we're experiencing a lot of that with COVID-19. And that is basically used to relax all of the musculature across the chest and the back. Anything that could resist movement of the chest wall, we want that to be ablated, and so we often paralyze our patients. So how do we do that? We use a cocktail of medications. So propofol, which if any of you've been in theatres will know is the primary induction drug that we use in anaesthesia. It's a white solution as an emulsion. That usually generates only hypnosis and sleep. It's got a very minimal analgesic effect. We then often, for analgesia, use fentanyl, which is a very potent mu opioid pure agonist, and that's given, both of these are given as infusions and sometimes as boluses if we want to get patients deeper quicker. The main paralyzing agent we use is a drug called atracurium. It's very, very loosely related to the original dextrotubercularium, which is from the poison arrow frog, if you're that way inclined and wanted to know that. And we choose atracurium because it naturally breaks down of its own accord, whereas most of the other drugs require good renal and hepatic function to be fully excreted. When we wean from these three, atracurium we can just turn off, but sometimes we have trouble weaning from extended periods on propofol or fentanyl, and so we'll sometimes use some other agents to augment sedation, and those two main ones are dexmedetomidine and clonidine. Don't worry too much about the specifics. These decisions will always be made by intensivists. And we always try and wean the sedation wherever possible. We know that being too deep for too long is a bad thing on critical care. And in terms of weaning, there's a couple of different sort of options available to us. We sometimes just do a cold sedation hold, so we'll just stop the sedation and allow the patient to wake, often to assess their neurology. You'll often hear that term on the ward round, and that's just making sure that the patient hasn't sustained some form of brain injury, and also so that we get the sedation right. If we just keep running the infusions, we effectively pickle the patients in the sedatives. Some practitioners will also try and aim to have an opioid-only sedation, so not worrying so much about rendering the patient unconscious, but keeping them analgesed and pain-free, and that's usually part of the weaning process. And through all of this, you have to be aware that some patients can suffer quite marked withdrawal symptoms as a result of that, which will need some form of treatment. So cardiovascular control and support. In our ICU at the moment, there's very limited cardiac output monitoring. And that's only going to get worse as the pandemic progresses. So for the majority of the time, the main parameters that we'll be looking at to measure our patient's cardiovascular state are the simple ones, which is just the heart rate and the blood pressure and potentially the capillary refill. And we use them as surrogate parameters for cardiac output. If we have a continuous cardiac output monitor, we can sometimes use that, but at the moment we are just so short, and the likelihood of you seeing much of that is going to be very slim. So how do we manipulate the different aspects? Well, if we look at the blood pressure as being the key component, the blood pressure is sort of a combined interplay between the fill status, so how much intravascular volume, how large the intravascular space is, or how filled they are. The systemic vascular resistance, which is the arteriovascular tone. So if patients have got severe vasodilation, that will influence their blood pressure. And then also how much blood is actually coming out of their heart at any one time. The systemic vascular resistance is affected in lots of different ways. Sometimes it's sepsis related, so the inflammatory response to the ongoing sepsis causes a vasodilation, and that will drop the blood pressure. With the cardiac output directly in and of itself is a product of the heart rate, so how fast the patient is pumping, and the patient's stroke volume, which is how hard or how much blood is ejected per heartbeat. And it's the combination of those two that provide the cardiac output. And we can manipulate these different things. We can manipulate the fill status by administering fluids, which in turn will increase the stroke volume. We can use iono or chronotropic drugs to affect the cardiac output, and I'll come to the next slide and tell you a little bit about that. And then we can also tighten up or squeeze the arteriovascular bed, so tighten up, increase the SVR, and that will raise the blood pressure. Generally speaking, to raise the systemic vascular resistance on our ICU, the primary drug that we use is a drug called noradrenaline, but sometimes we also use vasopressin. And the main inotropes, so inotropes are the drugs that sort of increase the kick of the heart, the amount that it squeezes. The main drug that we use is adrenaline, and also that has a chronotropic effect as well, so it's covering both of those. So in terms of the inotropes, there are three broad effects that you can achieve. You can squeeze the arteriovascular bed, and that's by using noradrenaline and vasopressin. You can increase the kick of the heart, so how hard it contracts. And we use two drugs, primarily adrenaline is the most, but sometimes we will use dobutamine, which is a pure beta-1 agonist. And sometimes we pace the heart, so increase the rate that it pumps, when that's chronotropy, and really the main drug that we use for that is adrenaline, but sometimes also dobutamine. The vast majority of patients with COVID-19 are just needing noradrenaline. They're vasodilated partly from sepsis and potentially also from the sedative drugs that we're having to give them. And that's the main drug that you're going to see being used. The other factor is that although we mentioned that fluids can be used to increase the cardiac output by increasing the stroke volume, as in how much fluid is in the left ventricle when it squeezes, we tend to run our ARDS patients relatively dry because they leak fluid into their lungs. So if we administer more fluid, a proportion of that will just leak out of the alveolar vascular bed straight into the alveolus itself, and thereby making their condition worse. So we tend to run our ARDS patients relatively dry. So what is ARDS? Well, there's an acronym for acute respiratory distress syndrome, and literally it is little more than damaged lungs. That's what it means. There are the classical ones of extrinsic causes and intrinsic causes. So the extrinsic causes are burns, sepsis, and pancreatitis, and the intrinsic causes are basically pneumonia or chemical inhalation. It looks like this on the chest x-ray with patchy infiltration throughout the lungs. And sometimes you can have consolidation on top of that. So pneumonia might be the primary trigger, so you might have an area of consolidation for the specific lobe, but then also have this patchy infiltrative spread throughout all of the lungs. It's defined as an acute onset with no known pulmonary hypertension, the bilateral chest x-ray infiltrates, which you can see on this film here. And also there's a specific calculation that we do, which is the PaO2 divided, so the PaO2 in millimeters of mercury divided by the FaO2 defined as a fraction. So if the patient was breathing 100% oxygen, then the FiO2 would be 1. If they're breathing 50%, it will be 0.5. If the PaO2/FiO2 divided by the FaO2 is less than 200 or less than 300 millimeters of mercury, because there's two different criteria for this, you're defined with these other parameters as having ARDS. And it's pathologically described as a leak of fluid into the alveoli initially, followed by stiffening and fibrosis, and also invasion of the alveolar spaces with white cells. It has 3 distinct phases, but this is way beyond anything that you need to know. But that is what we talk about when we say about ARDS. And how do we manage it? Well, just like everything in medicine, primum non nocere, first do no harm. Avoid a high FiO2 leading to hyperoxic lung damage. If you have a very high FiO2 fraction, a very high percentage of oxygen, this leads to a develop of hyperoxic radicals within the lungs that damage the very lung tissues themselves. To try and prevent that, we can use recruitment maneuvers. In effect, basically, it's the equivalent of taking a big deep breath, but rather than sucking air in, which is the normal respiratory pattern, we basically give a large breath and hold the pressure to try and open up and expand the lungs. It can be quite dangerous. It can lead to quite violent swings in the blood pressure, because as you expand the lungs with positive pressure, there's reduced venous return, because the pressure within the lungs prevents venous blood from getting to the heart, and you can get quite profound swings in blood pressure. So you do need to be careful when you do this. And then over time, we do something called PEEP, which is positive end expiratory pressure. In essence, instead of allowing the patient to breathe out to air, which is of 0 atmospheres effectively, we put a bit of resistance in the circuit and hold the pressure there so that it splints and holds the alveoli open. Instead of them just collapsing down as they vent to air, we splint and hold them open using what we call PEEP. This is also the same thing as CPAP, which is continuous positive airway pressure. The slight difference between the two, for those who are very interested, is PEEP is usually part of a function within ventilation. So you would have, say, an inspiratory pressure or an inspiratory volume and then PEEP on top. CPAP is really a definition of a treatment that is used for patients who are hypoxic, where all they're getting is positive pressure ventilation, either through a mask or a hood. But that's sort of splitting hairs, I guess. We also avoid volume trauma. We don't want to overexpand the lungs. We've proven that in trials that it's a bad thing. So we tend to keep the tidal volumes, so how big each breath is. So one breath is what we call a tidal ventilation, at 6 to 8 mils per kilo of the ideal body weight of the patient, which roughly is your height in centimeters minus 100 if you're a male or minus 105 if you're a female. So if you are 175 centimeters, so just shy of, I think it's 5'10", then your ideal body weight, if you're a man, would be 75, and if it was a female, it would be 70 kilos, and we use that to calculate the tidal volume. We also employ restrictive fluids, which can, because we don't want fluid leaking into the lungs, which can in and of itself lead to an acute kidney injury. We generally tolerate relatively high PaCO2, so as we reduce the amount of ventilation, we can end up with a buildup of carbon dioxide in the patient, which in turn can lead to a respiratory acidosis. And we tolerate this up until a point. We're sort of balancing off ventilating the lungs harder to try and get the CO2 off with injuring the lungs in the process by ventilating them harder. It's a juggling act, and you'll learn about this more when you get onto the unit. We often paralyze the patients again so that we make sure that there's no restriction to breathing because of the intercostal muscles squeezing, or even the anterior chest wall or the muscles of the back. So by inducing paralysis, we relax the patient as much as possible. And worst comes to the worst if we have starting to lose control with the patient in the supine or the slightly head up position that we normally use on ICU. We'll sometimes prone the patient. So we literally turn them so they're lying on their front for a limited period of time, just as a rescue maneuver. We usually would only do it for about 16 to 24 hours as a maximum, and it's occurring with more frequency than we normally experience with COVID-19 patients. So what are the ventilation basics? Well, I covered what PEEP is, and that's that pressure at the end of your expiratory phase. So as you breathe, what you normally do is you take a sharp breath in, and then you breathe out, and then you have a pause. And then you breathe in and out and have a pause. And in that pause, if we hold a bit of pressure in place, which we almost always do for all our ventilated patients, we call that PEEP. That's the thing you can control. And otherwise, realistically, there is only two things you can do with the bellows. You can either say how far the bellows move as you push it down, and that is volume control. Or you can say how hard you want the bellows to be pushed and ignore how far they go, and that's pressure control. From a physiological point of view, it is generally better to use pressure control ventilation, because in your lungs, you're going to have alveoli at different stages of expansion. So in theory, there's a group who will only snap open and shut again at the very top pressure. So if you use volume control, the pressure will go up and up and up and up and up. As the bellows go down, it will reach the maximum pressure at the end of expiration and snap back down again. And in theory, there's a whole group of alveoli within your lungs that will be sitting there waiting to open until waiting to the higher pressure. And then when the higher pressure comes, they snap open and snap shut again. And that can induce something called atelectasis trauma, or essentially a physical shearing force against them that damages them. So generally speaking, on ICU, we aim to do a pressure control ventilation. I'll talk to you a little bit about that on the next slide. And then those are the control ones. So that's what we have full control of ventilation. So the patient isn't doing any breathing for themselves. They're fully flat and we're just doing everything for them. And then we have the support or assist modes. So in this mode, the patient starts to breathe. The machine will detect a little bit of inspiratory flow through a flow sensor in the circuit, usually in the machine. And then it will then support that breath by giving a little bit of a push. And it assists breathing, and it's part of the weaning process. So we tend to go from a mandatory ventilatory mode through to a supported breathing mode, finally to extubating. It's a very slow and gentle process. So what are the common ventilator modes? At the Lister at the moment, you're going to see lots of different modes. Part of that is because we're using different machines. And part of that is also because we're using, patients will be in different states through the process, from being fully ventilated to having a degree of support and everything in between. And so you'll see lots of different ventilatory modes. But as I said, roughly speaking, there's only those two real options available to you. Some common acronyms you're going to see now. Part of the change of the different acronyms is simply because some of them are copyrighted by the different companies. And so when other companies have come up with their equivalent mode, they've had to give it a new acronym because the previous one was copyrighted. A classic example of this is BiPAP. BiPAP, as far as I'm aware, is owned by Draeger. And so no one can use the term BiPAP apart from them. And it is annoying at the very least, confusing and potentially dangerous, but essentially if you follow the original principles that you can either volume push, pressure control push, or support, that's pretty much all of ventilation in a nutshell from a critical care perspective. However, there are a few modes you do need to be aware of. The first is SIMV. It stands for synchronized intermittent mandatory ventilation. So it is predominantly a mandatory mode. So the machine is generally giving breaths at a fixed rate, but it has the ability that when you're in the expiratory phase, instead of just keeping on hammering away like a metronome, during the expiratory pause phase, when it's just sat there, it will sense the patient. If the patient tries to take a breath, it will deliver a breath on top. So it sits between a mandatory mode and a support mode. So if I put the laser pointer on, right, so if you have a look at this, this is a Marquet Servo I ventilator. This is one of the ventilators we actually have at the Lister. This first breath, if you look at this pressure curve here, so this is a pressure curve. So it's detecting the pressure within the airways. The first thing to look at is there's the PEEP value there, which is 9, and you can see these are set by these individual knobs down there. This patient's doing very, very well because they're breathing room air at 21% oxygen. But if you look at this first breath, nothing happens, and then it goes up to about 23 centimeters of water as the upper pressure. I can see because that's the upper number here, that's 23. And then it pops back down again, and then it sits there and waits. So that was a mandatory breath. So the patient didn't trigger anything. The machine just said, right, it's my turn. I'm going to deliver a breath. But then if you look here, if you can see the continuous line, you can see just around there, there's a little red undertick, and there's another red undertick there, and there's another red undertick there. Now, in those situations, what happened is the patient generated a little inspiratory breath. The pressure within the airways dropped down as the patient breathed in, and the machine noted that that happened, and it went and gave a breath in. It's actually set the mode as to PRVC, which is the next mode, the acronym. It stands for Pressure Regulated Volume Control. Now, this is basically SIMV. The volume is set by the operator, but it's a slightly fuzzy logic way of thinking. So the machine, instead of just pushing the bellows until it hits, in this case, 340 mils and then releasing, what it does is it tries to do pressure control ventilation where the pressure is fixed to achieve the tidal volume that you want. So every breath, so let's say the first time you set it, it will give, say, 10 centimeters of water. It will see how much volume that achieved. You'll get to, say, 200. It'll look and say, right, well, I wanted 340. I only got 200. So next breath, it'll try and give another 2 centimeters more, so it will go to 12 centimeters of water, and that gives 250. Not enough, it will go to 16. Oh, that hit 360. Okay, that's too much. So then it backs it off to 15, and it does this every breath. So every cycle, it's seeing what it needs to do, and it's adjusting the pressure to go up or down to achieve the total volume that you require. It's sort of a fuzzy logic type of ventilation. And then there are the support modes. You'll see lots of different acronyms. And the main one is pressure support. You'll also see CPAP ASB, which stands for continuous positive airway pressure, which is that sort of PEEP mode, with assisted spontaneous breathing ASB. It's a spontaneous mode, and basically what happens is, in this instance, the machine basically just waits for the patient to trigger, and it then delivers a supported breath. And it's part of the weaning process. And it's generally quite easy to wean from this because you get to see how fast the patient is breathing and how well they're doing. And what you can do is you can, over time, just wean away the pressure support until you can finally take the tube out. And that roughly is what we do for ventilation. So we tend to go from a mandatory mode where everything is fixed and in place, and then transition over to a spontaneous mode and then extubate, at least if everything's going right. Unfortunately, as you can appreciate, that isn't the trajectory of every ICU patient, and sometimes we have to do more complicated things than that, but that is essentially what we're dealing with. So, renal replacement therapy. So the first thing to note is this needs a dedicated line. The idea is that venous blood is taken out from the patient, it's run through or washed, if you'd like, and then it's transfused back into the patient again, this time with as many impurities taken out as is possible. The dedicated line we use is put into a central vein. We call it a vas cath. It's basically a very, very wide bore cannula with 2 lumens at the very least. So one for taking blood out and one for returning blood back to the patient once it's been cleaned through the hemofilter. Don't have much evidence, but roughly one hemofilter machine operating properly is about 30% of normal renal function. So it's definitely not the same as a normal kidney, but it's better than not if you've got no renal function at all. There are multiple indications for it. One of them is fluid overload. So for some of our patients with COVID-19, we sometimes want to run them particularly dry. So you'll see us taking lots of fluid off. And also we can generate an acute kidney injury by running them intravascularly dry already. So sometimes a higher than was normally expected proportion of our patients with COVID-19, despite it being a respiratory illness, are coming in with acute kidney injury. It can also be used for removing toxins, such as tricyclic antidepressants or antifreeze. It also is used to modulate severe acidosis. For example, in patients who are floridly septic and have got severe acidosis, we can use the hemofilter to take the acid away, and also to control severe electrolyte imbalance, such as severe hyperkalemia. Usually some form of anticoagulation is required. In our center, what we do is we give the anticoagulant just before the filter, and the filter then filters an element of that out. But we need some anticoagulation, otherwise blood will just get into the filter and block all the tiny little fibers that are running through the filter. To give you an idea of what's going on with the pump, I'll turn the laser prompt on. So this syringe here usually contains the anticoagulant that will go into the top of the, it'll actually come into the bottom of the circuit here. This is the main driving pump that drives blood down through and up through the hemofilter. And these devices here are controlling the electrolyte that's running on the outside on both sides of the membrane and controlling how much fluid is taken off. You'll usually have bags underneath containing the fluids that will go into the patient, and this last bag here is the effluent. Don't worry about the complexity of this. These are managed by the nurses. They are far, far, far more skilled at talking about this than even I am. In fact, not even I am. They are better at this than I am. So feeding. Nutrition is absolutely key to recovery and critical care to avoid a catabolic state. What we don't want is our patients to end up basically starving during a period of time when they probably need more calories than is normal. And also it's important to maintain gut health. A large portion of nutrition to the gut lining comes through the enteral route. So if you starve that gut, then you've got the risk of it failing, and you can then have translocation of bacteria direct from the gut into the bloodstream, which can lead to florid septicemia. We generally insert nasogastric tubes as soon as we can on admission, and we start feeding as soon as we can. We usually confirm the position of the nasogastric tube using an aspirate and a pH test. But if that isn't possible for whatever reason, then we need to do a chest x-ray, which at the moment we would ask that it would need to be signed off by a radiologist. The dietitians review the nutrition on every patient, often generating a custom feed depending on the patient's electrolyte imbalance and state, and also their weight and their general calorific requirements. What you'll often be asked to do on the unit is to prescribe drugs such as prokinetics. So these encourage gut movement, because when we give patients drugs like the opioids or the sedatives, it can reduce the amount of movement of the gut or induce a gut stasis. And the main two drugs you'll be asked to prescribe are erythromycin and metoclopramide. And just be aware, TPN, or total parenteral nutrition, this is where we give a feed directly through a central line, usually in the neck or in the subclavian, is a last-ditch bridge. If the patient has got a gut, it's really important that we aim to feed it that way. I hope at this point you've had a chance to look at the chest x-ray and you'll have noted that this NG tube is not in the right position. What's happened is it's gone down here, down through the trachea, gone down through the bronchus, and is now sitting in the left lower lobe there. So just be aware, NG tubes must cross at the midline before going into the stomach. If there's in any doubt, get a radiologist to review it. Okay. Do not feed if you saw a chest x-ray like this. So structure and routine. This is how the unit is currently functioning, and just to be aware that that may change depending on how things are going. We hand over as a minimum twice in the day. Once is at 8 o'clock and one at 8 p.m. And at the 8 o'clock meeting, we'll prioritise immediate tasks such as discharging patients as a priority. And then we'll have formal rounds. We tend to do a formal round in the morning, with a sort of a top-up executive round done at about 4:30, so between 4 and 4:30, just to see if there's been any changes and make any last decisions based upon any of the things that we enacted in the morning. And then at the night team will do another round as well to generate a plan for their shift. As a general rule, activity in the unit should be maintained 24 hours a day, but we do tend to reduce things a little bit at night time, if only because there are less staff around. One of the key things I think you will be almost certainly involved in is updating the handover sheet, and that sheet is critical to allow us to function and make decisions, because it's the only way we can retain information about our patients. So for that point of view, you will need to gain access to the V drive, to the critical care admissions folder within it, so you can change those, you can update the handover sheet and also the admission and discharge letters. At the moment, the unit is currently spread across 4 particular sites. The original critical care is CCU South, CCU Central, or Critical Care South, Critical Care Central, and Critical Care North. South and Central are designated COVID areas, and CCU North and Recovery are the clean ICU. So for those patients who are not COVID-19 positive, this may change depending on how many patients we get in. And our spillover for additional spaces, if we need it, is currently what used to be ACU and is now called ITU2. So you can appreciate we've got a group of ICU locations that are all around level 4 within the main tower, which is great. It keeps us fluid and able to move around them. And then we have this almost satellite unit set in ACU. So you may be aware you may be split away from the main team. As it currently stands, this is the structure of the ICU. Now we've moved on to the COVID rota. There is, during the day, 3 ICU consultants, each of who will have a group of trainees under them that may be comprised of registrars or SHOs or yourselves. And we will vary the mix depending on what the ICU consultants are doing. We then have a dedicated ICU consultant whose role is just outreach. So they will be out seeing patients who may or may not need to come to ICU, and also to coordinate between the different teams. Normally one of the ICU consultants will be nominated to be a coordinating consultant, so won't be so involved with the ward round and the care, but will just be keeping an overall view and overall picture of what is going on. And sitting beside the ICU consultants are the 2 merit teams. The merit team stands for medical emergency resuscitation and intubating teams. The current operating procedure is that when a patient needs to come to ICU, particularly a COVID-19 patient, the merit teams, having been reviewed by the ICU outreach consultant and deemed ready, time is right now to come to ICU, one of the merit teams will up and deploy and go and intubate and stabilize that patient and then bring them back to the intensive care unit. Each merit team should comprise of a senior anaesthetist, a junior anaesthetist, an ODP, and a runner. And we may, depending on how you do, fill you in onto these merit teams. It all kind of depends on how things are going at any one time. We don't yet know how it will be. That's our current operating procedure at the moment. It will obviously depend upon our staffing levels, but that's currently the way that we're thinking how we're going to operate. So where do you fit in? So the first thing to say is that traditional rank structure is gone. We will be operating and functioning on roles based upon competency and experience and not pay grade. Doctors are doctors, so we are expecting everyone to muck in and do as much as they can. I'd ask you as a consultant and a colleague just to read the situation and understand that I do paperwork. I'm happy to review chest x-rays, order films, go onto ICE and order blood tests as much as the F2 or F1 or anyone. And it's just about everyone mucking in and getting everything done for the good of the patients. We think to begin with, yes, your role will predominantly be doing, for want of a better word, the scut work, paperwork, ordering tests, writing the charts, but also communicating with patients if they're awake or communicating with relatives. These are all part of things that you can all actively be involved in. If you are surgeons, you are naturally hand-eye coordination and procedure-related people, and that is awesome because we have enough procedures to do on ICU. So once you are trained and happy to do the procedures, then we will be looking to you to carry on with this, whether it's doing intravenous, basic cannulas, central access, arterial lines, or even a PICC line. And also, each and every one of you brings specialist expertise to the intensive care. There will be plastic surgeons among you, orthopedic surgeons, general surgeons, and there's no reason why patients on the intensive care will not need specialist expertise. So if you have that expertise, use it. If there's a patient that needs it, get in there, give us a consultation. You may even just have the best connection with some specialist nurse who we need to engage with. Whatever it is, bring your expertise. We would love to use it in the intensive care unit. If you want to remember anything and be useful on the rounds, then sometimes it's just the basics that we need to cover. And there's this little acronym, FAST HUGS, that stands for these different components here. So if you're on the round and you see that there's a particular problem, or maybe someone's missed something, maybe we've skipped the venous thromboembolism, thromboprophylaxis, then you can easily chirp up on the round and in the most humble and engaging way, charming way, just say, oh, look, hang on, I've just noticed it. Is there a reason that we've not prescribed dalteparin? Do you want me to prescribe some dalteparin? Or head up? Or is there a reason we've got the patient flat? Do we need to think about glucose control? All of these things every patient should have. You know, we're humans. When we do the rounds, we miss things. It's entirely possible, and you might spot that. And, you know, you as a doctor on the unit, it's up to you to communicate to us as the team, and the team say, hey, have you forgotten X, Y, or Z? There's no room for hubris in this department, and we don't generally endorse it. So that's it. That's it from me. Just lastly, again, to say thank you so much for volunteering up to come in. We welcome you with open arms, and we hope you have a great time with us, and you get something out of it, and we get something out of it from you as well. And good luck, and stay safe.